So thank you very much for joining us, Dr. Karen. I really appreciate your time. Where are you joining us this fine morning?
From southeast suburbs of Melbourne today.
Fantastic. How's the weather in Melbourne? I was actually just there a couple of weeks ago, and every time I go there, just in terms of rain, so I'm just used to the Sydney weather here.
Yeah, well, look, it's not humid, that's for sure, and it's a bit cool today, but it has been very hot. So, look, like you, I flit around the country a bit, so sometimes I have to check where I am.
Yeah, fantastic. I guess there's a lot to talk about today. I guess I would love to start with your personal journey. Who is Dr. Karen Price beyond the titles and leadership role? In terms of where growing up, what was the key moment of why you became a doctor to start with? I would love to just touch on start off with that.
Well, what a funny question. Well, I grew up on the Mornington Peninsula of Melbourne, and uh, middle child of between two brothers, and we had a pretty typical childhood of playing poison ball in the road and chasing each other around the neighbourhood, and don't come home till it's dark, which was pretty great. Look, I think I'd always wanted to be. I can't remember a time when I didn't think about being a doctor, whatever that meant as a kid, and or maybe a teacher. And in the end, we all become teachers, whatever we do, whether we're in trades or whether we're in professions or even as a shop assistant, we all end up teaching. And that's the nature of humanity, isn't it? We learn from each other. So I think I had a lot of illness when I started school, which was just basically repeated bouts of tonsillitis, and I actually got scarlet fever, and in my later life was told that I've actually had some damage to a heart valve from rheumatic fever, very mild, and not didn't account for my lack of sporting prowess. But anyway, never mind. So I don't know whether that played a part. I had a very dour, very taciturn Scottish GP growing up, Dr. Stevens, and it was forever jabbing me with penicillin needles, which for a little kid, that was pretty tough. And I used to say to him, "Surely there are tablets. Surely there are tablets." And then had a great adolescent GP, Dr. Davis, who was fantastically empathic, and I think that really cemented my desire to combine what I was discovering in myself, a love of maths and science, with also some of the humanities and people. And medicine gives you an opportunity to do any or all of those things to varying extent. So I think it was motivated by altruism and some ignorance.
Absolutely. Wow. How was obviously, back then in terms of what medicine and becoming a GP has evolved over that period of time. In terms of going through the process of becoming a GP, how was that for you to start off with?
Yeah, well, it was a time when women were beginning to enter the medical world in bigger numbers, and certainly there've been lots of women before me, but not probably to the same extent. I think we were about 30% of our year back then, and now it's 50% or so, even more, I think, in some. I know the GP registrars, it's about 65% are women. So we were an anomaly. And certainly some of the aged professors would comment, and the boys love to tell us this, that women were wasted in medicine because we'd all go off and have babies. And as I said in a recent talk to the registrars, well, I certainly proved him right, because I was married before I finished medical school. I didn't have children, but I was married then, and I still am, and have subsequently had kids. But when I graduated, I was a married woman. So, and there was certainly prejudice about that, because I can remember trying to go for rural practice at one of the large hospitals in an interview, and they said, "Well, what about your husband?" And I went, "Well, that's up to him and I to decide, isn't it?" And, you were seated on a low chair with a ring of 30 people around you, bespectacled men. I don't recall any women being there.
Yeah, well.
And it was all about whether or not my husband was portable, which was ridiculous, given that I was expressing an interest in going to a rural location. So that put an end to any rural aspirations.
Yeah, absolutely.
It was very different, and but we found a camaraderie amongst the women in our medical cohort, and it certainly never felt that, apart from the bias and the prejudice, the women certainly did well. So we just carried on doing what we had to do.
Yeah, wow. That's obviously, it's definitely changed over time.
Yeah.
And especially to 50%, that's a massive number over the years. So, in terms of what it looks like now, if anything, that there's uh, things have evolved in terms of obviously culturally, and even in terms of from an international perspective, we do have international doctors coming as well. So
We've got an
have you seen
international world, so why wouldn't we have international doctors? So,
that?
they provide great service to our country. There's just a challenge in some of the workforce issues regarding low and middle income countries regarding losing their talent, which is a pity.
Mm,
But that's the nature of humanity. From many eons ago, people have always moved for economic reasons to look after their
mm.
families, and that's, our work is a part of that infrastructure that we have.
Absolutely. And it definitely shouldn't be, based on gender or roles and whatnot. Definitely should be open. It's an interesting in terms of the world where we are at the moment, especially around the DPA, locators and the requirements of moratorium and how that's shifted over time. Your thoughts on what it did look like before to what it is now, or what I guess what's your thoughts of that evolution, and where do you see that going?
What I think now is that we've got wonderful international medical graduates who are advocating now, who have come through the system 20 or 30 years now, who are advocating and opening up this dialogue, which really needed to be had, because we were putting people into situations for which they weren't prepared, and that is unfair. So, and it was unfair on patients ultimately, and that's who we serve. So the Lost and Labyrinth report from 2012, highlighted the challenges of international medical graduates being sent out to places without any cultural training or even support. And it's hard going for any doctor.
Mm,
Professional isolation is a real curse. And back then, of course, there was no internet, and as easy as it is now, compared to back then, communication from afar. So I'm really pleased the college has set up a national committee of international medical graduates chaired by Professor Ayman Shenouda. And I think on the forums that I see, the one that I moderate, GPs Down Under, there's certainly a lot of empathy for international medical graduates. And I frequently see healthcare leaders thank international medical graduates for their contributions. And there's also the pushback that why should we call people IMGs? Because they're Australian citizens, they're paying their taxes, what the hell? And I also understand that, because no one likes to be categorised in a general box. However, I guess there's the workforce statisticians use categories to allocate workforce, and that's been the way it's filtered down. But it sadly has become a shortcut for a whole body of different contexts and different people and different needs. So I think we're addressing those better. We still have a long way to go. The challenges of rural maldistribution are significant. It's not just about medical workforce, it's about all professional workforces, teachers, it's about skilled tradespeople, it's about infrastructure in NBN, it's about schools and hospitals and all of the infrastructure that we might take for granted in an urban situation. So this is much bigger than medical workforce. As I used to always say back into the Department of Health, well, let's talk about the geopolitical movements of population, because there is a drift back to the cities. During COVID, it became more a drift back to regional. So I think it's a complex cultural issue. I think with technology, we're bridging some of the gaps of professional isolation, which are really good, and we're looking at some of the more supportive roles. And I think it's more than just the geography and more than just the latitude. I mean, I used to always quote Cloncurry and Julia Creek in Queensland, which are about, I think, 200 kilometres apart on the same latitude, and they have very different workforce issues. I mean, Cloncurry has a lot of registrars, a great general practice team based there with lots of allied health, and Julia Creek can sometimes struggle. And the difference is the commitment of the local GPs there and the teams that they've built and the relationships. So it is more than just the location. My daughter was a John Flynn scholar and sadly couldn't convince her to be a GP. She's about to finish her endocrinology training. But she found that sometimes the community itself was not welcoming, and she's has the advantages of being, not an IMG. And she felt they were saying, "Oh, you're a city girl, you wouldn't understand." Well, that kind of pushback from the community was a challenge to her, and she thought, "Well, I'm not welcome here. I don't belong here." I've also seen up in Mackay a young GP registrar who loved working in the clinic, a great clinic, lots of support for medical purposes, but her own cultural faith group wasn't there. So she felt she wanted to move back to an urban or bigger regional area, which had a faith-based community that she could belong to. So this really talks to the, we talk about professional isolation, but also the social isolation that medicine can put upon people. I watched my daughter move around from hospital to hospital, the challenges of long hours, how that can disrupt people who are non-medical, who would otherwise provide support. The times when she hasn't been able to be at family gatherings, things that she's missed out on. These are things that we all know as medical people. And if we're moving all the time or we're a long way away from people who support us, who are non-medical, this has an impact on our careers and our longevity in that place.
Yeah, absolutely. Do you feel that obviously since COVID, the telehealth world has just evolved and enhanced? Do you feel that's obviously it's a pro within our industry in terms of the way it's moving in terms of telehealth?
It's a pro as much as the car is a pro and a con, right? So car is a great innovation, but it also has its problems. So telehealth is still evolving. And look, we've always had telehealth, right? How many times as a GP have I called patients up and talked to them about their results and or issues, or they've called me and we've made some kind of decision over the phone. So, and provided that all for free, on my altruism. So telehealth was an innovation of the government to fund doctors for the work that they were already doing. In terms of its professionalisation, which I think that's what's happened, we're using video technology platforms and obviously the telephone. I think there's a way to go yet. I still don't like seeing a new patient for the first time using these modalities because I like to get a feel of the person, get some context to them, have a more empathic bond with them, as you would expect from a family physician. And I can understand then subsequently a need to address certain issues by phone or video. But not everything can be converted to that. But in rural contexts, I think it's brilliant. And I think we need to be thinking about how we do some of our education, how we might do some case conferencing via video links and telehealth. I think that's a great support for many doctors in many different contexts. So I think there's great applications. What I don't like seeing is the fragmentation that it's as the opportunists move in with business cases to funnel a particular often single issue of medicine, and they market directly to patients. Patients are not consumers. I hate using that term consumers because that is part of the commercial determinants of health, and we don't want to turn into a US-style health economy. So I think some of the telehealth needs to be legislated, that there's a closed loop of communication back to the GP, and a closed loop of communication does not mean the My Health record. It does not mean just something put into a uniform electronic healthcare record. It does mean handing back to a particular GP so they know exactly who and what has been done to their particular patient, because we know continuity of care needs to be preserved. And what I see is fragmentation of care and opportunists, and that's not good for patients.
I actually just came back from Turkey very recently, and I was exploring in terms of their healthcare systems and other healthcare systems around the world. And it's very interesting to see that in Turkey, it's a dedicated GP for that area and that patient. and that's it. There's no going to another GP and it's you've got a dedicated GP and that is it. And that GP knows the family history and knows the complete history of that patient. So
It's
I,
good
I
to learn
do
from other health
want
systems.
yeah, absolutely. I definitely want to touch on the general practice world and kind of where we are at the moment and the mission behind general practice. So it is known that general practice is often called the backbone of the healthcare system, and what drives your commitment in growth and sustainability. So one of the questions I had was, what do you believe is the most misunderstood aspect of general health, both by the policymaker and by the public?
Uh, the skill of a GP, the scope of practice of a GP, the scope of practice of a general practitioner is immense. It is infinite, in fact, because anything, everything, and all the time can present to general practice. And we triage appropriately. So that means we manage most of it. We refer on a small fraction of it. Even if it's referred on, it comes back to us and we continue to manage. Everything a subspecialty doctor sees, we have seen first and diagnosed mostly appropriately. And we continue with that management. So we farm out very small tasks and we do most of the management and the coordination of care. And this speaks to the 4 C's of general practice, which are absolutely not understood and they're not reinforced by the system. And we know that continuity and comprehensive care are absolutely so important to patients, because without that, we hear about the latest sort of political cry that women aren't being listened to, but I wonder, and that's fair, but I do wonder how many have gone to GP to GP to GP to GP, and they're starting at the top of the diagnostic algorithm. I mean, you and I both know that abdominal pain in a young woman is an extremely common presentation. And it takes some time to go through a diagnostic algorithm over a few different consultations. But if you don't stick to the same GP, you go back to the start like snakes and ladders every time. So the continuity of care is really important. And being able to be comprehensive in your diagnostic approach, so that you can pick when it is inflammatory bowel disease as opposed to a sexually transmitted disease or endometriosis or irritable bowel, whatever it might be. So I think that broad diagnostic scope is not understood, and the 4 C's of primary care are not well understood. And there's an idea, because people see that we refer, a lot of the allied health and subspecialists might see what we refer to think that that's the majority of our practice. It is not. The majority of our practice is maintained, managed, and sorted within our own walls. And we know that across the population, we have the best outcomes. The primary care paradox by Kurt Stange has shown that if you have too many subspecialties managing a patient's condition, they might do it all to the guidelines. And we have to remember the guidelines are not evidence-based medicine. If they do that, they often have iatrogenic harm. Whereas if you have a GP who coordinate that care, who knows the patient, who has a patient-centered approach, a whole-of-life course approach, there are better outcomes, even though it may not always be to the guidelines. So it's a real paradox. And I think that complexity is not understood, nor is it understood how general practice sits into the whole system. We're not the saviors of the universe. Nobody is. But we are very important parts of a health system, and it must be integrated through general practice.
I feel like you answered the question, but so in terms of how do we ensure GPs remain at the center of patient care while adapting to the evolving healthcare model and the system in itself?
Yeah, it's interesting, isn't it? So evolving healthcare models is, I think, sometimes a bit of a furphy. We've got this thirst for innovation and novelty, and we're like little monkeys in a tree looking for the next new shiny thing, right? So, but at the end of the day, humans and our presentations and multiple presentations of different ailments have remained reasonably constant. There is obviously some evolution in diagnostics and so forth, but our ailments probably aren't dissimilar to what was experienced hundreds of years ago. And the nature of humanity in its anxiety over health and what health means, which is a social, cultural, and emotional and spiritual feeling of well-being, that hasn't changed. So we've always adapted. GPs were the first part of the medical cohort to put computers on their desks, with encouragement, of course, but we were the first to computerize. And when something works, we took it up with great gusto. I mean, the vaccination clinics were set up by many GP practices. Telehealth were taken up in great numbers by practitioners throughout COVID. So if something's not taken up in a great way, it's not because we're laggards, it's probably because it doesn't implement into our workforce. So AI is an interesting one. I think that's going to be, I think scribing is a real benefit. I think it's still in its infancy. There's challenges with the wordiness of AI, but I think the ability to code general practice encounters is going to be interesting. And I only hope they use appropriate codes for general practice and don't use disease-based coding as they do in hospitals, because there's, the ICPC3 coding that Wonka have developed allows a contextual development of general practice presentations. Whereas when we use some of the other ICD codes, they're very disease-based and fragment the patient. So we've got to make sure that when we use AI, we're not using something that's been adapted for a hospitalist-based or a US-style health system, that it's actually adapted to our whole person approach to in general practice, which is what we do.
Yeah, fine. If you could change one thing about how general practice is valued within our healthcare system, what would it be? Funding.
10% of the health GDP needs to go to general practice. It's about 11% in Denmark. I mean, we saw from Jen Sondergaard his amazing presentation at GP 22 on the integration of a healthcare record, the lack of a barrier between hospital and primary care, the ability for GPs and practices to sort of benchmark their work against other areas, balancing the socioeconomic needs, because your outcomes are going to be different in a high socioeconomic area compared to a low. So comparing one to the other is a nonsense. So being able to interrogate your own work in a self-reflective kind of way, but also in a practice-led way that you can implement the needs-based interventions into as a whole practice. So I think we need to have much greater investment in the power of general practice, and we need to have general practice leaders and advisors within these forums, because the many I've been in, you're often the lone voice, and it's a surprise to people that what they're trying to implement, you just put your hand up and say, well, it's not going to work in general practice, and they really have no idea. They have a genuine desire to try, but the system is not set up for general practice. It's set up for a hospital-based hierarchy, a large organisation with HR infrastructure and all sorts of budgets, but that's not the case for many general practices. And we're distributed over Australia, but collectively we are a huge organisation, but we don't have the organisational structure of a large centralised organisation. And that difference of implementation needs to be appreciated within the system of care.
Do you feel that message has changed though over time? Obviously, moving from 30% to 50% in terms of women, that message has slowly been received.
No, I think over my lifetime, unfortunately, I've seen a degradation in general practice in the value and respect given to it, and I think that relates directly to funding, and one keeps supporting the other, and then we have the mischievous advertorials where the grifters and grafters start to say, well, I saw this, we can do this better in a single task, the taskification of general practice. They're there to make a commercial buck and not really thinking about how their work can disrupt an entire system of care. Then also not thinking about people who might find care hard to access. And the inverse care law is still operable in a great extent in Australia, and the models and new models that are being developed, sadly, will degrade that access further. General practice is the best way for the vulnerable cohorts to access healthcare, and therefore the insurance that the government provides to the patient needs to reflect that need of access. It's not up to GPs individually to save the health system. That's up to the government and the allocation of appropriate resources to one of the best bangs for bucks they can do. And, I think the colleges and the AMA would be very happy to help whichever government, Labor or Liberal or whoever gets in, to develop a really sexy campaign based on the support of general practitioners. But at the moment, it seems that even the young journalists think that healthcare, whenever you get a healthcare story, they show a picture of a hospital. And that's, we know the ecology of healthcare, that's where least healthcare occurs in a hospital. Most healthcare occurs in the community, and much of that is coordinated through a general practice. So it's about time our media and our politicians reflected where most of the community gets their healthcare.
Yeah. It's very interesting in terms of what especially around the funding from bulk billing to private, and how general practices have evolved and moved down the road of mixed billing or privately billing. And I guess, how have you seen that impact the community from your perspective, in terms of that shift in mentality, specifically by GP owners?
Well, we have populist politics, and that's a pity. We have both sides of politics using bulk billing as a proxy of healthcare success, and that's a nonsense. And it's just electioneering, because there's no mention of quality, and it's very hard to provide high quality care for complex patients with large needs on a bulk billed budget. And there are many admirable GPs who work in low socioeconomic areas who try and manage this, but they generally have to see a high volume of patients. So they might bring a patient back 2 or 3 times a week, whereas in a mixed billing practice, if they were adequately supported, you might be able to attend to that all in one go. So bulk billing is a proxy for low productivity, because that person has to come back 3 times a week, or may also have to get childcare, may have to take time off work, or maybe not looking after their elderly parents or something in the community. So there is a productivity cost to bulk billing. And during COVID, 90%, I think, of the population were bulk billed. And whilst that was very necessary through a global pandemic and rapid access, I don't think either political party, even though they say free healthcare as an election slogan, I don't think either of them believe that the federal government can support free healthcare for all. And we live in a community. We live in a collectivist society, regardless of what some people think. We all cross-subsidise each other. I drive on roads that someone else has built. By the time I'm aged, in the last 2 years of my life, I'll probably use up a whole lot of healthcare resources that younger people have paid for. And there are disabled people who and lots of people who may never contribute in tax dollars, but who we, as a compassionate society, support. So we really have to think about our collectivist approach to funding healthcare. And I don't think that people who can afford to pay a small moiety towards a healthcare cost, I think that's a good thing, because it helps us as doctors then cross-subsidise at a local individual level in an intelligent way that the government couldn't possibly do. So we have a proxy of disadvantage being a healthcare card, and we know that has plenty of challenges in it, because there are some who probably shouldn't be on a healthcare card and some who aren't on a healthcare card who should be. So it's a reasonable proxy. It's probably the best we can do. But a local GP who knows their patient cohort can really cross-subsidise at a very micro-intelligent level, because I know this person who's bringing back their sick child, each day of the week because they've got asthma that I need to monitor, or they've got an illness that I really want to keep an eye on. I may end up bulk billing the latter part of those consultations, or giving them just the rebate so that they have access. So it's not a barrier to access. But if, it just depends. And so I can decide based on hopefully some fat in the land provided by other people who are able to pay a gap. I can provide some substitute care. And I think that's a way of our collectivist society working in a good way. So it's a real challenge for those doctors who work in low socioeconomic areas, and that has to be addressed by the politicians. Unfortunately, they've used things like urgent care centres in marginal outer seats of the electorate, and have promised free healthcare, which is a nonsense. It's not free. It's heavily subsidised general practice. I've asked the question and got a deafening silence. Well, who are you turning away? If it's only acute care, then who are you turning away? They are heavily subsidising general practice care, and they're taking GPs from elsewhere. And it's an absolute admission that the Medicare rebate for the rest of us is woefully inadequate if they're having to pay $200 per encounter in an outer suburban seat. And that's simply because it's a marginal electorate. And there is a workforce failure there for that reason. So, whilst they band-aid all of these little problems, they create bigger ones down the track. And I do think they need to really seriously show some leadership on the Medicare rebate, which is the patient's rebate. It's the patient's taxes. That's why we pay taxes, so we can access healthcare and education and roads and everything else. And sometimes we do cross-subsidise each other. The pharmaceutical benefits is an example. We have a safety net for people who are working who have high healthcare needs. There are ways and means of managing the cross-subsidisation that is difficult using a large strategy like a healthcare card. There needs to be more nuance per context.
What do you think about the
complicated topic, healthcare funding?
It's definitely you can go on for hours really. They've recently obviously introduced the July change. Initially it was supposed to be in November and now pushed it back to July, the MBS update around chronic disease management and kind of the funding around that. Have you had much of a chance to review and take a look at that?
No, I think, is that the one where they're going to they're going to push up the reviews, and it's just going to be one GP management plan, not the team care arrangement as well, and change some of the. Look, it's a great idea to be able to do a chronic disease management plan. You've got to have a practice set up to do it. What happens, as I'm sure every GP knows, is you get people coming in saying, "Oh, my physio or my dietitian or my podiatrist says just get the EPC, the enhanced primary. I just need my visits subsidised," and they often tack that on the end of a consultation, and they don't understand the process that this is actually a GP management plan, and they need to have a proper management plan done. To do a really good one, I like to prepare it before the patient comes in, because you can't really do it when they're there. I find it very difficult because you need to talk to them about it, and so you haven't prepared it yet. So personally, I find it a bit clunky, and the clunkiness of having to get a specialist ear, nose and throat person to sign off something when they've already been involved with the patient's care just seems like an enormous waste of everyone's time. So I think if we can streamline some of those things and put the reviews in, it becomes better, and we might continue to develop better practice systems for good quality care plans. The other issue being that I've had the experience too, like everybody else. This has even happened to me when I was president, that one of my patients who I've seen for 30 years and will continue to see until I die or they die, one of us will die first. And they had, when I was president, not as easy to get to see me, so they went to someone else as a one-off for an acute self-limiting condition and got a care plan. And that's really frustrating, to see that kind of thing happen. So, we need to be able to make sure we're also being professional about our use of them, with the way that they're used. But unfortunately, because of the impecunious nature of general practice, there's been a system-wide challenge to doctors and practices, and that's been a problem. And so we've seen the compliance increase on that, which is, it's part of a structural reform that we need.
It's definitely so one of the I guess the point is to register the patient in My Medicare, and then they're eligible for the care plan. I guess there's the compliance component, and then there's the actual implementation and training of that within the practice in itself. So if you are to do a change, then how do you go about implementing that change across all the general practice, and then them being well equipped to handle that change? And what we found is that the staff in itself, by the time the change happens, then the practice being equipped and ready for that change, we're finding that there is a struggle and there is a lag between.
Absolutely, a lag time. And this also speaks to the payroll tax issue, where we're all running our own practices within a tenanted arrangement. Whereas in the past, I think there's been an attitude that you were not an owner, and therefore not able to direct receptionists or nursing staff to do certain workflows. Whereas now I think that's changed, thankfully, and people are starting to see themselves as independent business owners, which is a good thing, and that's an appropriate change. Payroll tax is a whole other issue. But I think the ability to institute administration change, and particularly for part-time doctors, for people who are not used to speaking up for their needs, you need to go to a practice that has these systems in place so that you can actually perform high-quality work and not make it every time the government changes something, there's a disruption that is chaotic and not well implemented at a local practice level. So, and the government needs to think about how much red tape is involved in these Medicare issues, because reading Medicare is a legal document. So do we really need to go and get a law degree to understand Medicare? I think that's a nonsense. We've seen a proliferation of, Medicare education sessions. Well, that's starting to become absurd and ridiculous. We really do need to simplify the system so the doctors can get on with doctoring, and nurses can get on with nursing, and the receptionists can get on with doing their wonderful jobs at the front desks, because otherwise it's just so clunky and so complicated that we all sit there with, and probably many of us undercharge.
Do you feel that in terms of the resources that are out there at the moment, they are equipped in terms of, whether it's through the RACGP, AMA, other bodies, practices are equipped to handle such changes at the moment? It's quite, that's in terms of interesting whenever we're actually going out and working with these practices, just seeing the level of difference. You have someone that's doing amazingly well, and then someone that's just, struggling and just trying to stay above water.
Some people are extremely busy. So, the education is out there for sure. And there's to say, well, you must just go and do it. However, there are some people who don't have a lot of protected time. I can remember listening to a podcast when my kids were teenagers. I got interrupted every 6 minutes. So this idea that you can do a podcast at home on, something, protected time is really difficult. GPs are hardworking professionals, and the education they do is on their own time and their own money. So we're having to spend money and time learning a government system that is so complicated that we have to take time off to understand it, or rely on others to help us decode it. And that is, again, a waste of resources. It really needs to be simplified. And I do think there's a movement within the Department of Health in a federal level to try and simplify it. And certainly the AMA have come out with their 7 levels of item numbers, so time-based. Some of the other changes I think are helpful, but we don't want hospitalists in charge of general practice billing, because they see everything in terms of, the little toe resection versus the big toe resection, versus whether there was an anesthetic applied or not. I mean, this is very task-based healthcare. We need more comprehensive healthcare item numbers that reflect the time and complexity that we spend with patients, because you and I both know that a patient doesn't come in with a single issue. They come in with multiple issues. And depending on our practice style, we may need them to come back, obviously, but sometimes we try and deal with many of them in one go. And that can violate Medicare just by doing that, just by the patients presenting as they should for access to healthcare, violates the way that Medicare works. Now that has to be looked at.
And definitely then that impacts the quality of care that's delivered to the patient themselves. So yeah, absolutely. The healthcare within this country is ever evolving rapidly. What wisdom can you share with those leading and practicing within the general practice today?
think to lead with mission before ego. You're going to win some, you're going to lose some. Government do have a difficult problem. I mean, I spend a lot of time, critiquing government, hopefully not criticizing, but critiquing, which is a democracy. So I hope the politicians welcome my critiques. They need to hear from their stakeholders. They need to hear how it implements, because they don't often hear that up in the echelons of Canberra. I think be true to yourself and be true to your professional values. And we've really got to hold on to our quality of care, and we've got to hold on to our professional values. We are not a traditional business market because we don't sell products. We sell services. We sell healthcare services, and the patient who is in most of need of those has the least ability to pay. So we are not a traditional business case. There is a social contract of healthcare that the electorate has with the governments of the day, both federal and state, and it's a complicated dance that we do around the ethics and the need to sustain a business model that works, that's not too tied up in red tape. So I think keep on critiquing. You are going to sometimes get politicked at. And the politicians are very good at that. They're very, very good. They're quite smart people. And they're very good with their words, and they're very good at playing the media. But you've just got to keep going. And our strongest advocates, of course, are our patients, and bringing them along on our journey of making sure they can demand adequate healthcare wherever their context is really, really important to GP leaders everywhere.
What's one piece of advice you wish you had known earlier in your career?
Oh, only one? I think medicine, first of all, it probably attracts obviously it attracts high achievers. It attracts those who are a bit driven, and then it reinforces it, right? So, and we get and we usually, especially in general practice, fairly altruistic people. So we put others first pretty much all the time. And we've got to be careful that we include, and I say this to patients, you've got to include yourself in your own circle of care. So I think being gentle on ourselves when we get tired, being able to recognize our signs of burnout, and that we don't have to pick every fight. We don't have to fight every fight. Being strategic, learning to keep quiet is quite a skill. So I think these are important issues for going forward. So the self-care, picking your battles and applying your wisdom wisely. I think it's only experience can teach you, but can learn from others. And I've watched other people ahead of me work out the political strategies, and I've taken, just mental notes about how wisely they do it. And you can also learn from the politicians too. I mean, they're pretty good at managing a room.
You touched on a very important topic in terms of GP wellness within our country, in terms of seeing burnout. I guess, how do you manage, burnout, manage stress in a very high demanding role of your experience in your career, and what advice would you give others in terms of managing that stress, because it is a quite demanding industry we do play in. What advice would you give?
Well, for me personally, it was having a large degree of control over my flexibility, so that if I had one patient who was, I'll just call her Mrs. Sparkly, and I loved seeing her. She was absolutely gorgeous and delightful 90-year-old who was fit and active and just lit up the room whenever she came in. And I saw her on a regular basis. And when I got irritated, when I saw her name there and I was irritated, I thought, oh, you're a bit burned out. You're a bit tired. Because I didn't have the energy to be responsive to this bright and sparkly person who I really genuinely cared about. And I think that was a bit of a signal for me. So knowing my signals, and having that degree of control. So I had my own practice at this point, when I had the 3 kids at school, and my husband traveled a lot, so it was often me on my own. So I would try and finish earlier ahead of, maybe it was 2 weeks' time, I would knock off a few appointments, or I'd come in a bit later, or I'd take an afternoon off or a day off just to control the workload, because a working parent with kids, running a business, partner off and away is a heavy load, and you need to look after yourself, because we all know that a burned out doctor doesn't deliver as good care. Now, that's a lucky position because not everyone has that ability to knock off some appointments. I didn't have to explain myself to anyone, and I was a business owner, so there was an ability to have fat in the land as a whole of practice coordinator. So for other people, if they can at all get some time out, if not from medicine, then from other tasks in their life, that's really important. Other factors, of course, we say exercise, trying to develop a regular habit. And for me, walking my dog, who's now passed away, was a great source of joy. And friends and family, and being connected. I think feeling supported in my own community. So I spent 25 years running small group learnings in my area. So feeling, the anxiety of missing diagnoses, and the general anxiety of just being a doctor, and the responsibility and conscientiousness that we have is quite a heavy burden. I mean, I don't know a doctor who cares, who hasn't lied awake at night worrying about a patient or a decision they made. So sharing those worries and concerns with other colleagues, and being real in those authentic conversations. That was my PhD. Getting that informal debriefing that you need when you've seen someone who's irritating you, or you can't work out the issue, or you just don't feel quite right about where you're going with this particular patient. Even asking someone, what was the name of that new hypertensive drug starting with D? What was it? Someone you can ask those questions without the medical student thing of feeling that you're not smart enough. Of course you're smart enough. There's just a lot to learn, and none of us know it all the time. So both the emotional workload of general practice needs to be recognised. You often need a rest from it. You can get debriefing from your peers. And I think if it gets too much, go and seek some professional counselling. And I've certainly done that in my time when I've needed some support. So, it's part of the resources we have as a community, that we seek support when we need it, and we seek it early. And that means we have to recognise our own signals for when things aren't really right. And if obviously you have bad days, but if it's persistent, then you need to take it. You need to have the ability to take some action.
How do you see the future of general practice, and what changes need to happen to keep it sustainable?
Well, the fundamentals of high quality health systems haven't changed. So, general practice delivers the best population outcomes. We need to partner more strongly with public health units in our area, and public health units need to think that we're not the GP intern. We are the operational arm of the work that they do. We need to obviously we make sure we are efficient, and we know that general practice is the most efficient, not fragmented into disease-based clinics like endometriosis clinics, headache clinics, quit smoking clinics, skin clinics, you name it, clinic. General practice is the most efficient. And we need to have the patient's experience of receiving that healthcare to be good. They need to feel good about going to see the doctor. So we do need nice buildings. We do need nice, well-maintained rooms, modern rooms. We need good infrastructure for telehealth and video consultations. We need good equipment. So this needs money. This needs resourcing. Patient's experience includes all of that, as well as obviously having doctors who are not feeling so pressured that every minute they're burning themselves out. We need to have doctors who feel they can spend the time with their patients, so that longer consultations, complex consultations, don't become a burden, and we're trying to rush people out the door or refer them on to everybody else simply because we know we can do it, but we haven't got the time. So I think the Medicare system needs restructuring to enable some of that patient experience to be better. And we need the physician experience of delivering healthcare to be good. This is the quintuple aim, including the equity and the population outcomes. Physicians need to feel great about what they're doing. So if we're always hearing from the politicians negative commentary. And I know Professor Louise Stone at ANU and Adelaide University has done some word clouds on some of the rhetoric coming out from Canberra. It's been really disappointing to see the negative rhetoric that's attached to general practice as opposed to other parts of the health system. And I think the governments of the day, the health departments need, and the media need to really be very careful about how they're destroying trust in what is a really wonderful institution of primary care, and general practice in particular, who should be the leaders of primary care because we have the most qualifications.
Touching on leadership, if you had to summarize your leadership philosophy in one sentence, then what would it be?
Only one sentence. Well, when you're a leader, you're in the service of those who've chosen to follow you. So it's a great privilege and it should make you humble, and able to consult with those who have elected to follow you or who encouraged you to lead them. You need to have a constant dialogue. So it's not one sentence, it's many, but in the service of others is leadership. And knowing who those others are, and there may be multiple others. So in medicine, we serve patients. Medical leaders are actually in the service of patients accessing healthcare, and they do that by making sure the physicians that they look after are well resourced, and making sure that the structures that they sit in are working properly. And really, that's all in the service of good patient care.
You're welcome. Finally, looking back at your journey, what is the legacy you hope to leave behind?
Find your voice, speak up, don't be afraid. It won't always work, but keep talking and keep speaking in a respectful manner. Learn how to dialogue. I think my legacy will be I did write that down. I hope I'm a continual annoyance to the grifters and the grafters, because I really do believe in quality healthcare for all people. And to do that, you've got to really push back on some of the commercial determinants and some of the, as I said in another article, the adverse lobbyists who are just there for self-interest. So mission before ego is really important, and understanding where we sit in the whole infrastructure, and respect for each other and for every person who comes through your door. Everyone's got something to teach us, even if they're our worst enemy. Sometimes it's good to have a quick listen. Not to all of them, maybe some of them.
Absolutely. Thank you very much, Dr. Price, for joining us today. I really appreciate your time, and I hope we can touch base soon.
Oh, thank you for asking me, and carry on.